Hello, I'm here to talk about chapter 28 today. This is the audio lecture on chapter 28, exercise and activity. Um, Walking, whether you're turning, lifting, or carrying, are all common actions, and they're used to provide nursing care. Such activities require muscle exertion. You need to practice proper body mechanics as a nurse and remain knowledgeable about research standards and guidelines concerning safe transfer, positioning, and techniques to reduce the risk for injury. Okay, so when we discuss scientific knowledge base, we're going to discuss um, what we call is body alignment. Body alignment basically refers to the relationship of one body part to another along a horizontal or vertical line. Correct alignment reduces strain on musculoskeletal structures and maintains adequate muscle tone, and it also contributes to balance. Body balance is achieved when you balance a relatively low center of gravity over a wide, stable base of support. A vertical line falls from the center of gravity through the base of support. The base of support is actually the foundation. When the vertical line from the center of gravity does not fall through the base of support, the body loses balance. Coordinated body movement is a result of weight, center of gravity, and balance. Weight is the force exerted on a body by gravity when you lift an object. You must overcome the weight of the object and be aware of its center of gravity. In symmetrical objects, the center of gravity is located in the exact center of the object. The force of the weight is always directed downward. An object that is unbalanced has its center of gravity away from the midline and falls without support. Friction. Friction is the effect of rubbing or the resistance that a moving body meets from the surface on which it moves. As you turn, transfer, or move a patient up in bed, you need to overcome friction. Remember, the greater the surface area of the object you move, the greater the friction that is generated. Regulation of movement. Regulation of movement is the coordinated body movement, which involves the integrated functioning of the skeletal, muscular, and nervous systems. Because of these three systems, um, they cooperate so closely with each other mechanically, support of the body, they are often considered as a single functional unit. The skeletal system is composed mainly of joints, ligaments, tendons, and cartilage. I do want you guys to be aware of all the things that I've been saying. I want you to know the difference between what body alignment is, what body balance is, coordinated body movements, and friction. And I also want you to know what the difference is between the skeletal system when you talk about things like this joints. A joint is the connection between bones. Each joint is classified according to its structure and degree of mobility. Joints are classified as fibrous, um, being made of cartilage, and being also made of what they call synovial connective structures. Fibrous joints have a ligament or a membrane that usually like unite the two bony surfaces together. Cartilage joints has little movement but is elastic. This type of joint allows for bone growth. The synovial or true joint is a freely movable joint. Bony surfaces are covered by cartilage and connected by ligaments lined with synovial membrane. An example would be something like the hip joint. So, what I want y'all to know is that what is a ligament? A ligament is a white, shiny, flexible band of fibrous tissue. It binds the joints and connect bones and cartilages. What are tendons? Tendons are white, glistening fibrous bands of tissue, and it connects muscle to bone. Tendons connect muscle to bone. So you got to know the difference. And then you have what they call cartilage. Cartilage is non-vascular and is supporting connective tissue, and it's firm and it's kind of like a plastic like material, and it permits uh, weight and your ability to sustain weight, and serves as like almost like a shock absorber pad between bones, or articulating bones, so bones that come together. So the good thing, and then there's the nervous system, which is proprioception and balance. Those are the things that the nervous system work with. Body mechanics: do not use manual lifting when you need to lift most or all of a patient's weight, and you use safe patient handling equipment in conjunction with agency lift teams. So, in other words, what they're basically saying is that it's best for you to use like a Hoyer lift or something like that when you're lifting a patient, instead of trying to lift within itself, or to use someone to assist you when you're lifting. So you have a case study of Mr. Indelicato, is a 72-year-old African American who is hospitalized for surgery. He's going to have surgery to his right knee. He relates the problem with his knee to previous sports injuries. He first sought medical advice and treatment 6 years ago. He has various treatments, including physical therapy, rest, and pain medication, which is um, uh, ibuprofen 600 milligrams every 6 to 8 hours. And he's a very active individual. You have a Marilyn Sweeney, 40-year-old nursing student. She has just finished rotating through her orthopedic rehabilitation division of the agency. Her assignment is to follow the patient through his surgery and his rehabilitation. So, as Marilyn, the nursing student, prepares to assess Mr. Indelicato, she reviews anatomy, physiology related to the musculoskeletal system, and exercise physiology. So she knows what a ligament is, she knows what a tendon is, cartilages are, and joints, and what the purpose of those are. Okay, scientific knowledge base. Pathological influences on body alignment, exercise, and activity um, could include things like congenital defects. Congenital defects being things that people have regarding to abnormalities uh, that may affect alignment or balance. Uh, like, for instance, osteogenesis imperfecta. It's an inherited disorder that affects bones. Some characteristics of, of this particular disorder means that they'll have increased fractures and bone deformities. Um, a person may have a scoliosis, which may be a structural curvature of the spine that's associated with vertebral rotation. So there's a lot of different things and ways, like congenital things that people are, uh, I guess you could say, affected with. So, disorders of bones and joints and muscles could be things uh, like osteoporosis, which is an aging disease where the density and that type of thing is of the bone is affected. You could have hormone imbalances which affect the density of the bone. You can have arthritis, inflammatory joint diseases of those type of things. You can have central nervous system damage, uh, which may affect your ability to move around. For example, if you're caring for a patient who experienced a head trauma, uh, and that damage was done in the cerebrum area, that amount that may limit their voluntary ability to move, because it affects the voluntary motor area. So a right-sided hemorrhage could make a person have hemiplegia on the left side, that type of thing. And then, of course, musculoskeletal trauma like bruises, contusions, sprains, and fractures could affect bones. Nursing knowledge base, growth and development. The body undergoes changes throughout your particular life's span. Newborns and infant spines flex and they lack anterior posterior curves of the adult. And as they grow, the stability increases. But from when you get older, there's changes in the musculoskeletal, development and them aging and stuff. So they may have limited, activity or patient activity as the result. They may have an osteoporosis or osteopenia or something like that. Um, behaviorally, behaviorally, basically, it's just talking about how a person treats their bones. Do a person exercise? Does a person move? Because you can have limited range of motion with your joints and things like that if your behavior, if you don't have a daily exercise routine. And then cultural and ethnic origin uh, uh, is just has to do with some exercise and physical fitness and stuff uh needs to be like tailored towards certain individuals to exercise and motivate them to do just that. So what you're going to do is you're going to critically think the knowledge, musculoskeletal system, exercise physiology, and health alterations or things that you're going to put together. You're going to think about experience, your experience, both personal and um, clinical, may um, ex- help you with assisting people with ADLs and how they move. And then attitudes, which basically mean that you need to be more creative. And then there are professional standards and guidelines through the Department of Health, uh, the National Institute of Occupational Safety, and et cetera, which has guidelines on how you can safely transfer individual. So, nursing process and it basically states that there's body alignment, and we discussed about body alignment, and The first thing when you're assessing a person's body alignment, you want to assess standing, sitting, and for them to be recumbent both. And you want to look and make sure that, like, when they're standing, their head is erect in midline and that their bodies are symmetrical. You want to look at the spine. You want to look at the abdomen and see if it's comfortably tucked in. You want to look at the knees and see if they're able to flex them and that the feet are flat on the floor. When they're sitting, you want to see that their body weight is distributed on the buttocks and thighs, and um, the thighs are parallel and in a horizontal plane. And you want to look and make sure that the person feet are supported on the floor, their forearms are supported on the armrest or in the lap, and you want to look at the alignment from that way, as well as when a person is recumbent and the patient is in the lateral position, and you're going to put one pillow up under their head, and the positioning supports removed from the bed, and you're going to look and see whether or not that person is aligned. And at that point, that's when you assess for decreased sensation, if there's any problem with circulation and that type of thing. So here is a picture where it shows where the center of gravity is and the line of gravity is, as well as even sideways. You can assess the person. So, as far as mobility, you want to see if a person has active range of motion or whether or not it's passive. You want to assess if there's joint stiffness, swelling, pain, or limited range of motion. You want to assess their gait and their manner and style and cadence and how they walk, their rhythm. You want to assess whether or not they exercise, and which means whether or not they have adequate muscle tone and strength and cardiopulmonary conditioning. And then you want to see if they do anything, what is their tolerance? Is there a tolerance as far as when they ambulate? Is there adequate tolerance when they bathe or when they sitting? You want to assess like their heart rate, their breathing, their blood pressure, all of those type of things to see how they tolerate activity. So, a patient with a long history of arthritis complains of sensitivity and warmth in the knees. To determine the degree of limitation, the nurse should assess what? You're looking for the degree of limitation. You're going to assess range of motion. Um, Next, you have the patient expectations. Remember, I told you guys throughout all the patient expectations, you want to make sure that they have realistic perceptions and that they are normal. Older adult considerations. They will have decline in physical activity, changes in their joints, chronic conditions that may affect their activity and exercise tolerance, and you want to do all that you can to overcome these particular things for these individuals. So you got Mr. Indelicato, and he doesn't want to ambulate, okay? And he rates his pain as 6 to 7, and on a scale of 0 to 10, and he's using what they call a PCA pump, a patient control analgesia, and his degree of knee flexion is now 70 degrees. He's able to ambulate 10 feet with the walker, and he further describes his muscle strength in his right leg as feeling weak and tired after walking a short distance. Uh, The student nurse Marilyn observes Mr. Indelicato using the walker incorrectly. Okay, so she sees him using that walker incorrectly. Okay, so you're gonna look at this gentleman and you're gonna say, okay, let's see what is some of the good nursing diagnoses that can go with him. So somebody with exercise problems and activity, you got activity intolerance, you got fatigue, risk for injury, impaired physical mobility, acute or chronic pain, risk for impaired skin integrity or impaired skin integrity. All of these things are adequate diagnoses for somebody who has activity problems with exercise and activity. So you're going to make sure that you have adequate goals and outcomes, and you're going to work with that patient. You're going to make sure the goals or the outcomes or measurable, when you're doing that. So you might say that that person, someone like Mr. Indelicato, he got impaired physical mobility. It seems like he got deficient knowledge because he doesn't know how to use the walker. It seems like he got fatigue when he walks to 10 feet. He got acute pain because he's a 7. And so you right there, you got 4 different nursing diagnoses related to mobility and exercise and activity with that one man. Okay, so what you need is teamwork and collaboration. You want to work with the family, you want to work with physical and occupational therapists. You want to prioritize based on the effect that the problem is having on that person's mental and physical health. And you want to work on those things. So first is you got to make sure you get that pain level down, because if you don't get the pain level down, Mr. Indelicato is not going to be doing anything. So you're going to make his goal that he's going to be down to 2 to 3 on a scale of 0 to 10 doing ambulation. That's an achievable thing. Uh, you want to ambulate him 50 to 75 feet instead of just 10 without him being tired. You want to gain a minimum of a 90-degree instead of a 70-degree flexion. And that he will also return a proper use of the walker demonstration. See, so those are realistic goals. And then you will set those goals with the time frame that's adequate. When, at the end of those, when. So you're going to focus on improving that exercise and activity, encourage patients to exercise daily. You're going to do it maybe 15 to 30 minutes. You're not going to just go on and on and on. And that's based on his weight, his fitness level, all of these things that you're trying to improve. And then you're going to do exercise and activity which can help return a patient to independence and a maximal state of health following trauma or illness. Okay, implementation, lifting techniques. We all have talked about this before, but I do want you all to know that you always keep your body close. Uh, you're going to keep whatever it is that you're lifting close to your body. You're going to always bend your knees. You're going to tighten your abdomen and your and tuck your pelvis in. And then you're going to keep your trunk erect and knees bent. Okay. When you are positioning a patient, you're going to always protect the areas of bony prominences, ankles, elbows, that type of thing. You're going to reposition the patients as needed, and at least every 2 hours if they are in the bed, at least every hour if they are sitting in a chair. Patients with contractures or who are at greatest risk for skin breakdown should be repositioned even more frequently than that. You're going to use devices such as pillows, foot boots, and trochanter rolls in order to position the person. You're going to use hand rolls and hand wrist splints because you're trying to uh, assist the person and make sure the person doesn't end up with contractures. There are devices like a trapeze bar where a person can help, like the picture here. Uh, you're gonna sometimes you may have to have them roll over by grabbing one side of a cell side rail and then wedge pillows to keep them in that position once you've turned them. But you always want to focus in on making sure that the person that you're assisting is trying to assist as much as possible. Okay, so we've talked about filers and semi-filers positions, supine position, prone, lateral, and why those particular positions are of importance. The Sims position, a lot of people sleep well with that position. Okay, transfer techniques. Get help to transfer a patient. Use assistive devices and use your critical thinking. Here, they have various machines, and I'm going to tell you, oh my God, you can go to the nursing staff and the technicians, and they will show you how to use all these various lift machines that can make it so much easier for you to assist someone who can't move and transfer a person and then at the same time keep them safe. Okay, so I would say that may be something that you may want to do this quarter is make sure that you learn how to maybe master how to use the lift machine or the Hoyer lifter or something like that. Joint mobility and ambulation. The mobility and ambulation, okay. What you want to do, you guys, is make sure the range of motion exercises active as well as passive. Passive, uh, 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 passive um, range of motion exercises or exercises that you're doing where the person basically they're not helping or they have the inability to help. And then you have what they call active, where the person is actually participating and moving their joints on their own. And a lot of times with the active, it's more uh, them trying to get stronger, you know. Okay. Walking. You're going to assist the patient to walk. You need to assess the patient and the environment. You need to allow the legs to dangle so they won't get weak. Like if you're sitting them up, you don't want them to get postural hypotension so that you will let them just dangle for a second prior to them standing. You can also use a gait belt in order to transfer them to a chair from one chair to another. And then maintain a midline center of gravity. So, right here is what they call a controlled fall. I have had incidences where I was helping somebody with a gait belt and the most important thing to do, you're helping somebody with a gait belt. You need to, and they start going down. No, you're gonna let them go down, but you're gonna control them going down to the ground. That way, there's no injuries, and that's the whole purpose of that. So you can look at this picture and you can see, you're not going to try to hold on to them. You're more or less blocking them from having a fall. Okay, so Marilyn with Mr. Indelicato, she encourages him to use his PCA pump before he starts to ambulate. So use the pain medicine. She tells him to dangle. Uh, she increases his walking by realistic increments. So he might be doing 10 feet today, and then in 2 days or 3 days, you may say, well, let's do 11 feet. You know, you're not going to go from 10 to 20. I need you to do 20 today. And he just did 10 yesterday. Okay, so you want to talk with him about his exercise tolerance so that you can know how much he's doing. As part of the teaching process, Marilyn consults with a physical therapist on proper use of the walker. Um, she and the physical therapist instruct Mr. Indelicato and family caregivers on the proper use of a walker and using that walker for him basically to get around, because a lot of times uh people, I don't know, the person's elbow first of all should bend comfortably about 30 degrees when they holding on to the grip. So that's how you know that it's not too short. And when the person relaxes their arm at the side of the body, the top of the walker should line up with the crease on the inside of the wrist. So, and then they hold the hand grips and they take a step, and then they move the walker forward, and then they take another step. So that's how the person should do, and they shouldn't lean into, the walker. So, so the walker, that's the correct technique that I described. Assistive devices for walking, you have things like you have canes, you have a single straight leg cane, um, and then you have a quad cane that they're showing in the picture here. And canes, they have to. It's almost like it's the same. Uh, you need to make sure as the nurse that you are standing on that person's weak side, whatever side for them is the weakest for support when they're using the cane. Uh, the patient can place the cane forward, and he or she moves the weaker leg to the cane, which divides the body weight between the cane and the stronger leg. So what they do is they always move the weaker leg to the cane, and then the patient then advances the stronger leg past the cane. So the weaker leg and the body weight are supported. Okay, so you make sure you always teach them that they have 2 points of support, such as body, feet, or 1 foot, and then one and the cane at the same time, like touching the ground at the same time. And then you have like crutches. Uh, when you measure crutches, um, make sure that up under the axillary, the crutches is more commonly used, and there are three common methods to measure the length of the crutches. One met uh, one way to do it is the first method that most people use is they multiply the height of the patient by 77%, or they subtract 16 inches from the height. So whatever inches they are, like if they're 70 inches, let's say, they'll subtract 16 inches from it. Okay. And then whatever, if it's 54 inches, then that's how tall that particular crutches should be. Or you can also measure by putting it up under the person's arm down to the bottom of their feet if they laying down. So people have their little technique, so this is the crutch stance here. And then this is the gait and how you go about it, with the crutches. If a person is, let me see, how can I say it? Like they have different points of gaits. And 4-point gait is alternating, or so the patient, it requires weight burn on both legs. You got 3-point alternating, or 3-point gait requires a patient to burn all of the weight on one foot. In a 3-point gait, a patient puts the weight on both crutches and then on the uninvolved leg. The 2-point gait is at least partial weight burn on each foot. The patient moves a crutch at a time, the same time as the opposite leg. So the crutch movements are similar to the arm movement doing normal walking. So just know that you know the difference between the 4-point, 3-point, and 2-point gaits when you're doing it. When you are walking up and down stairs, the patient stands at the bottom of the stairs, and then you transfer your weight to the crutches, and the patient advances the unaffected leg between the crutches to the stairs, and then shifts the weight from the crutches to the unaffected leg. Finally, the patient aligns both crutches on the stairs here, and then she repeats that, or he repeats that sequence when going up the stairs. Descending the stairs is uh, a patient also uses a 3-phase sequence. The patient transfers the body weight to the unaffected leg and then places the crutches on the stairs and begins to transfer the body weight to the crutches, moving the affected leg forward. And finally, the patient moves the unaffected leg, and then that's how they repeat that sequence. Uh, there are a lot of things. You can sit in a chair, as you can see how they hold it, you know, uh, first. Yeah. So after you do all of this, you mostly do evaluate the patient and your plan of care and whether or not it's working effectively and how effective. Like for instance, this nurse here, she rates Indelicato rates his pain level as a 3, and he's able to perform some range of motion and use the CPM machine, and he has a steady gait with the aid of the walker. So it has been 5 weeks since Marilyn began to care for Mr. Indelicato, and Mr. Indelicato has progressed steadily to increase both weight burn and range of joint motion on the affected knee, and Mr. Indelicato expected the pain to be completely resolved on hospital discharge and not to follow into physical therapy. Marilyn, the physical therapist, worked with Mr. Indelicato and his orthopedic surgeon to identify pain control measures. Okay, so, safety. You mentally review the transfer steps before beginning, assess the patient's mobility strength, determine the amount and type of assistance you require and explain the procedures, describe what you expect from the patient. So basically, what they're saying is you're trying to make every single thing that's going on pretty clear when you're actively um, doing these various techniques and stuff for the patient. So, um, exercise is a key. It helps in weight loss, it improves cardiovascular functioning, good for mental health, longevity, and it improves stamina. I would tell you guys if you take anything away, I would tell you these things when it comes to exercise and movement, and you may want to just put a little, make a little notation of these things as far as when it comes up with testing time. I want you to know about body alignment, body balance, friction. I want you to know about the difference between ligaments, tendons, and cartilage. Okay. I want you guys to know all y'all positions, which, we've discussed the different positions. I want you guys to be able to identify nursing diagnoses that apply to somebody with activity of having problems with activities. I want you to know various devices that we use for proper positioning and be able to describe what they are, like pillows, foot boots, trochanter rolls, hand rolls, wrist splints, trapeze, side rails, wedge pillow, and various types of lifts like the Hoyer lift and that type of thing. I told you I want y'all to know about the different positions like prone and lateral and Sims and those type of things. And we already have discussed that. So I want you to know the difference between the 2, 3, and 4 point gait when using crutches, proper use of walker, proper use of that type of thing like that, and yeah, proper positioning, and you should be do pretty good from there. Okay, so have a great one.